Welcome everybody to the Random Anesthesia Topic podcast. In this episode we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started.
Me hosting, right?
It is. Tasha, it's your turn. Go for it.
All right. And okay, so tonight we're going to do a little bit of a potpourri.
Oh.
And I have a set of hypothetical questions that I sometimes cogitate on in moments of boredom or procrastination. But the first question I have for tonight's talk is, if you were trapped on a desert island indefinitely,
Jesus Christ.
indefinitely, and you could only go with one drug for anesthesia, which drug would you pick?
One drug.
You get one shot, one opportunity.
Yeah, that's right.
You know what? I'm debating between alfaxone and ketamine.
Yeah, for whatever reason on this desert island, we also have a veterinary hospital where we do TPLOs, and I need to know what drug, the one drug that you're going to take to this TPLO only desert island. Interesting. Bailey?
How about you, Ryan?
I don't know, like, if it's not painful, I feel like Propofol, because it's just so smooth and nice, and you get a good anesthetic plane and hemodynamic stability. But like, if I don't have any analgesic drugs, what am I gonna do? I mean, so I feel like you're almost forced to be ketamine. Dexmed isn't powerful enough to like provide everything. Like it can't provide. I mean, so I think you have to choose ketamine.
I mean, you could go with a very potent opioid, right? I mean, you can use opioids for an induction.
But that's only if you're working with dogs.
True.
Oh, because now we go back to rats, cat, sympathetic tone.
Oh,
You can't anesthetize a cat with enough fentanyl, from what
I
I
thought
hear.
for sure, Ryan, you'd pick Alfax, because at least Alfax too, you can give IM, right? Because I never.
Alfax is a good. I just feel like with Propofol, Propofol is so reliable and so smooth, and there's no jitteriness, and like it is just like that's where all the evidence is, especially from the human side for the like Tiva stuff. So like, love it.
Yeah.
I mean, don't get me wrong. I'm a Propofol fan. I have like one of those little like chemical symbol necklaces that I wear sometimes.
Aww.
I know. Nerd alert.
Yeah, nerd alert. I mean, ever since my Tiva podcast, we're like, some days it's like 50%, or some weeks it's 50% of the cases are run under Propofol Tiva.
Wow.
Nice.
Yeah. I don't know. The techs love it. They're like, let's do it. And I'm like,
Yeah.
do we have to? Can we like just go back to ISO? Let's just like do some ISO today.
Yeah. ISO is overrated.
It is.
Oh, it's the root of all evil. We know that. Everything. Yeah.
They are just so smooth. Like it's so rare I have to do anything with those cases. It's just
Are you sure you don't want to pick ISO so you can mask them down? You can box them down, Bailey? Like, I know you love that.
The open drop technique. Or like liquid injection.
Oh, geez. I think
you could bubble it through the water. You could paint it on the amphibians. Like,
I wish I was one of those more seasoned, I'll say, anesthesiologists, and I could be like, I wish we still had like halothane or like urethane or like whatever.
Ether?
Yeah. One
God,
of them was
ether. Just such a good drug.
gross.
I don't know. We used nitrous all through my residency and no issues.
Yeah. I used nitrous a couple times. It's nice. Mm-hmm. But again, if you're doing anything that's not a dog or a cat, there are some issues.
Yeah. I mean, I'm not going to crank my cow with bloat full of nitrous, but I mean, there are no cows on this island, so don't make it.
Yeah, you're not doing 2 kilos on these horses.
Also, side note, I'm trying to be calmer tonight because last week's like podcast clips, I was like, oh, I need to bring my blood pressure down about work. So I'm just going to be nice and calm, courtesy of Italian white wine.
Lovely.
Yeah.
So, what's your favorite wine? If
Oh,
you
that's
had to bring a wine bottle on the island, which one would it be?
Ooh,
I'm going to pick a Viennese gemischte Satz.
I would what?
of course.
I'm going to pick a Viennese gemischte Satz.
Sure.
It's a blended white varietal from the Viennese hills. It's usually like it's old school, it's family made, it's a table wine, but it really goes down smoothly. And it there's so little sugar content and sulfite content because they don't export it that you don't get a hangover. So that's my pick.
Does it have another name, the grape? Or like the
No, because
wine
it's a
stuff?
blend of multiple grapes, right?
What grapes are in it?
Gemischte means mixed. So
Oh,
yeah.
Wow.
learn
How about
something new.
you? How about you, Beanie?
Ooh.
So 1 second, my dad is blasting the TV in the background, so I'm going to move locations.
It sounds so nice.
I probably, I mean, I really like Malbecs.
Mm. Anything in the Gamay family is just like I love a lightly chilled red. It's like one of my favorites.
Mm,
Just
okay.
A Petit Verdot,
like a red wine that you can just like slug down is just like the bomb.
that's exactly how you're supposed to drink wine. Just like open your gullet and neck it.
Yeah, yeah, exactly. That's my
Sure.
jam. I don't need those big, bold California Cabernet like Zinfandel or anything like that. Just give me like a nice lighter bodied red. I mean, I love a Malbec, but like the thing I drink the most is like Gamay, Beaujolais, anything in that family is just like it's my jam. It's my
I
jam.
do like a lighter red, some like blackberry, like heavy, like the Cab
Yeah.
Francs and all that kind of stuff. I don't mind those with the right meal, but I usually get like a spanking headache. So
Yeah. I hate when they have like high tannins and stuff. Like, I really hate that. I can't
there
deal
are
with
some
that.
filters that you can get that where you just pour the wine through, right? And it will take the tannin, and then there's a separate one for the sulfite because the sulfite is the preservative for
Right.
shipping, right? Which is
Yeah.
why it's always better to drink the local wine if you're wherever you are than it is to drink the imported wine because then you don't get that sulfite content, and that's a big contributor to that like hangover headache situation. So,
Yeah. I mean, I don't drink enough wine to like actually care, but
but you're Italian.
I get it. I get it. No, I'm not. I'm not actually. I think my transformation to American just, we went to Saturday for the first time. We went to the range, right? So
Wow.
I never shot before, and so
Oh,
like,
so it's just a gun range, or like you got to like lasso like burros?
no, no, it's just a gun range. So yeah, we shot a 9 millimeter and a revolver.
Oh,
It was my
handguns.
first time. I was like, actually pretty nice. We may go back for some rifles, I guess.
Drinking the
So
Kool-Aid, Beanie, drinking the
this
Kool-Aid.
is
I gotta get you up to Canada before this gets worse. Like, before you know it, you'll be eating, like, pizza on crackers and
Ugh.
so wait. So this place, so this range actually has a bar inside, right? So you could
perfect.
drink,
Alcohol and guns, nothing bad ever
Yeah,
happened with that combo.
nothing.
and we were like, "Is there any rule about this? Like, can you like drink?" And I was like, "Yeah, there's no rule. Like, you just whatever." I was like, "Okay." And
Oh
then like
yeah.
right beside us, there was like a family with like an 80-year-old just shooting like these massive rifles, and the kid was shooting too. And I was like, "Holy cow! I never seen
Wow.
This
this."
is like in parts of Southeast Asia where you can go and like fire off bazooka and, like relics from the Vietnam War, and you're like, I'm okay. I'm just gonna go for like foot massage. Like, I didn't feel like, you know,
I it
Just try
definitely
the
felt
local cuisine. That's plenty for me.
the
it
local cuisine
definitely
tends
felt
to be
really
exploded
America.
cow.
Yeah, it's fine.
It
Somebody eats
definitely
Yeah.
it.
felt really
All right, so
America
back
here.
back to our hypothetical desert island, where we're drinking Gamay, Malbec, and a Viennese gemischten
We at
Satz.
least have good wine.
Yeah, fuck yeah, and
We're gonna need it because we can only use one drug.
and
We need
ketamine.
it.
Yeah.
Okay, now if you, same island, same scenario, you're stuck there and you can only take one piece of anesthetic monitoring equipment, which one would you take?
Pulse ox.
Oh, interesting.
Pulse ox, huh?
What would I take? I mean, I guess I'd probably go with like a Doppler. It gives you so
Oh,
much.
What the
I
fuck?
cannot express to you the depth of my hatred for a Doppler. I mean, what a
Wow.
finicky piece of bullshit machinery that
Oh,
is.
and a pulse ox is not
I
finicky.
didn't vote for pulse
The
ox.
pulse ox I have, if it doesn't go on the tongue, it doesn't fucking read. And it's like the good quality one.
I didn't vote pulse ox. I would vote CO2. I'd go for
Another
capnography.
solid answer. You know what? That's a good.
That's
Yeah.
my choice. You can keep ECGs because they read on dead things. You can
Oh,
keep pulse
obviously.
oxes because they don't read on dead things.
Sure.
I hate Dopplers, and I
Oh,
always
hate
feel like when I'm putting
Doppler.
a Doppler on, like, what is this, like 18 feet? Like, are we
Oh my
using
god.
sonar? Like, I just know.
Love the Doppler. Get the signal. I am still proud of my ability to one shot a Doppler in any animal. Like,
Yeah, but what do you do with it? Like you hear it.
I mean, I take blood pressures with it.
Because
When like
the number
literally
you get, it's super unreliable, right? Like you know
they
that.
the texts are like, oh, the blood pressure's here and it was here and da 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 da. I'm like, put a Doppler on. Let's see what the Doppler says. Let's see which one it agrees with. And then they mess with the cuff, and sure enough, the cuff was like totally malpositioned. It's like
The
I had to
Doppler is bullshit,
I had to
especially
threaten the
Bailey
Doppler.
in cats.
Sure,
You know
sure.
it
I'm not
is.
like I get one piece of equipment. It's like CO2 only tells you the animal's breathing.
No, it doesn't. It tells you about cardiac output and it tells you
No,
about
not on
equipment
spontaneous
integrity.
respiration. Come on.
Come
Come
on. Come on. The Doppler
come.
does not
We
tell
don't
you
have a
anywhere
ventilator here,
as much as
Bartel.
the CO2. The CO2 tells you about equipment integrity, airway patency, it tells you about circulatory capability, and it tells you about ventilation.
Sure, I'm not
And you
disagreeing.
know
It
what
doesn't
the
do
Doppler
it.
tells me? This.
No, not
That's
if
what the
you're
Doppler
good. If you're an expert Doppler placer like myself, big crystal, all animals, never using that little crystal. I get it 100% of the time, every time.
100% of 100% of the time. That's not even statistically
Yeah,
possible.
I'm fucking that good.
You guys, I'm just sitting here and like seeing, watching the debate. You know, it's.
You can potentially tell pulse quality from it. You can listen for
Sure,
their
you can
response.
What
potentially
do you do with?
interpret mean and diastolic pressure, but then sometimes it's a false systolic pressure. But if you get the systolic, how do you know you're still not hypotensive? Because you can't actually read the pressures that matter, which are really mean and diastolic.
I mean, I never asked for a sphygmomanometer. I just asked for a Doppler.
Okay. So even more
So
you
then,
for you.
I mean, I guess you can just pump in the femoral
At least I
artery.
get to hear the
More
patient's
normal.
heartbeat. I don't have to like get my stethoscope and be like, "Oh, I'm gonna reach under the drapes, see if the dog's alive."
I mean, if you have CO2, you don't have to do that either.
That's true.
Also, the
I
Doppler is
just wouldn't.
affected if you give potent peripheral
Oh
vasoconstrictors.
yeah, for sure.
Now, back to Beanie's shit choice of the pulse ox. Um, Bailey, let's gang up on him and discuss
Which
that
pulse
because
ox
that
though?
was the worst answer.
Name the brand.
I don't know if we can do this, but you know, I love Massimo.
Sure. Yeah. That's. I mean, if
Yeah,
you're gonna get one, that's the one to get. Although I don't know what is
yeah.
with ours. It
This is
has to be on the
totally.
top.
This is for whoever's listening. This is totally non-sponsored.
Sure. Yeah.
We're not getting any money for this.
Clearly, this isn't sponsored. Who would sponsor us? Like,
Yeah.
Nobody.
you know what? The
But,
wine companies.
yeah,
Oh my
but I
gosh.
would use a reflectance probe.
Oh
Oh, look
God.
at you.
When the
Oh,
text
Bailey's cute new cat is here. Greaseball.
oh, Greaseball. Carol's gonna love when that happens. Oh my god. Stop. I don't want to grab you.
Oh, yeah, he does look like he's a little touch hyperthyroid there, Bailey. Look at that
I
tail.
know. I know, yeah. That's why his name is Greaseball. We're debating, I think the top contenders are Marv, as in Home Alone, and Mo,
I like
as
Marv.
in MARV.
Yeah, I like that.
Mo, as in Mo Cara, which is the Irish phrase for my friend, because we always refer to him as my friend, and we got him around St. Patrick's Day.
Oh,
Yeah, those are the leading contenders.
You see, he's got a Marv vibe about him. Look at him.
he does.
He does. I think
He's
Marv's going to
cute.
win out. But
Yeah.
Greaseball for now.
So why are you so against cold success? Like, what's your? It rarely fails me, right? Like, I rarely have issues, especially if you use the
Well,
right tool, which is, usually a reflectance probe does the trick.
if you are on 100% oxygen on our desert island where they have 100% oxygen, what does a 98% pulse ox really tell you, though?
That it has enough oxygen.
Does it, though? I mean, it tells you that technically, clinically, you're
Depends.
not going to be hypoxemic, but relatively speaking, you might be based on your inspired fraction.
I was like,
Does it matter?
what are the odds of dealing with hypoxemia in the small animal patient? Come on. Like, what are the percentages of small animal patients that are developing hypoxemia under anesthesia?
Well, if you're
I've
doing
seen it.
actually hard cases, Bailey, more than you think.
Okay, on this desert island where we have one drug and one monitor, we're gonna YOLO and fucking do like an open chest with manual ventilation, a pulse oximeter. Cool.
I
I'm
didn't say there
gonna
wasn't a
go drown
ventilator on the
myself in
magical
the
island.
ocean and hope a shark eats me.
Okay. But, I've definitely seen it. Like, I've seen patients that, where nobody actually ever heard a VSD in, and we anesthetized it. And actually, it decelerated. And we couldn't, we tried to troubleshoot a lot of things. And then all they were like, okay, let's put the probe on. And like, it had a right to left shunt. And so, we put on the right beat, we fixed it. But, you know, it does happen, right? Like, I mean, it's not probably common, right? It's
Yeah.
not something that you see every day, but shit does happen. I mean, your patients that you anesthetize and they have small amounts of calodorx and you don't know about it, right?
Yeah. Yeah.
I don't
Maybe.
know.
You know what I mean? Like, there
Pulse
is a lot
ox
of patients
also,
that don't.
I just don't like finicky things. That's why I dislike the Doppler, and sometimes the
How
pulse ox
finicky
is
is
a
it?
real
Like,
jackass.
what kind of
And, it
pulses do
doesn't
you
work
use?
if you're
What? We
dysrhythmic.
talk about capnography is not finicky. Oh my god, the moisture trap has the skosh of water. Every patient 10 inspired CO2, unable to resolve the inspired CO2. The little
I would say the
post.
percentage of time where I have to fart around with the pulse ox to make it work appropriately versus the CO2, that's probably a tenfold. The pulse ox is way more persnickety.
I do have one machine that's like I have to change the water trap every single case because it's just like, oh, the vapors, they've got me.
Okay, it's not Sunset Boulevard, Bailey. It's a desert.
All the other ones are good. I suspect there's just some sort of like internal something in there where it's like just highly sensitive because it has to have the pediatric water trap and like.
I think all of these pieces of equipment have a role to play in comprehensive monitoring, but that's why I specifically said you can only have the one thing. And I stand by my CO2 after that discussion.
Which style?
Side stream, Bailey. I don't give a fuck. Right? Like
I mean, there's merits to both, right?
yes,
The
I
rhythm.
wrote that essay on the exam and I'm not writing it again.
I
I
feel
did
that the
not have
merit
that
of the
essay.
mainstream is that it gets trashed really fast.
Yeah, that thing would get destroyed in your desert island.
Yeah, it's gonna get sandy. It's gonna cause
Yeah.
drag. They're gonna extubate. Like they'll have to give them more ketamine. Like no, 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 no. Okay, next desert island scenario question. You've landed on the desert island with another person who's decided that they've got nothing else to do but qualify as an anesthesia technician. What are top 3 tips or tricks that you would teach your new assistant or your new
Wow.
training technician?
Ooh.
Okay, number one, because this is.
Number
Well,
1,
I
get
just
the
got
Doppler,
one.
get the Doppler.
Number one, get the Doppler. Number two, only use propofol. Number three, fuck the pulse oximeter. No, for me, just the number one for me, and this is it's going to be really boring, and it's like, but do every case like the way you physically do the tasks, do them the same every single time and establish your own routine.
Love
And
that.
like, yeah.
Love that. Get faster, you get safer, you
You
get more
basically
efficient.
want the robot.
What's that?
You
Yeah.
basically
Oh,
want.
yeah. Like, I feel like I am an anesthesia robot. Like, every way it's the same every single time. And I can just, like, when shit goes wrong, you know it in your bones because the muscle memory is suddenly different. You're like, something's wrong. And then, like, immediately you start working through it
Yeah.
because there's a slight variation in the normal. I mean,
I like that. Yeah.
what other? I mean, that's like my biggest one.
It's a good one.
I got to think about the other two.
All right, Beanie.
I think definitely, get used to like touch the patient, like, make sure that
Oh,
you like, get, you're not getting too comfortable with just, the monitor sometimes. The other thing is probably you want to make sure that you're actually knowing what the drugs do, right? If this is a
I don't know if
random,
that's a tip or a trick. I feel like that's just a bug standard expectation, but yeah,
but that's not always the case though, right? Like it's
100%.
and then the third thing is probably like, I would treat, and probably this is the most important, I would treat them the way you wanted to be treated, right? Like the fact that they can't speak, it doesn't mean that they don't feel pain. It doesn't mean that they don't deserve to be treated like, you know, like we are, right? Like I know that, they're animals but we're animals too, right? Like
Yeah, we're the worst kind of animals.
truly.
exactly, right? And probably the
Ugh.
most destructive of all them. But, you know, unfortunately, sometimes I think there is a disconnect, right? And do like, oh yeah, that procedure is not painful. I was like, yeah, if they chop your
I
balls
mean,
off,
just do some horse
isn't that
anesthesia and
painful?
get into it with the horse surgeons about butorphanol and analgesia, and you'll be
Oh,
like, yeah.
Well, thankfully, I'm glad and I'm thankful that I work in a place where they do value that. And we use morphine on, almost any horse, like, that's getting a decent procedure, like, anything that's orthopedic, anything that's a major soft tissue, they get definitely, morphine. Even castrations, they do get morphine, right? Like, I don't think that chopping somebody's balls off, it's not painful, right? I don't know who thought that when you neuter a cat, it's okay to use kitty magic with torb in it. Like, also, what the fuck is kitty magic? I hate that shit,
I hate it.
right?
Hate it.
the,
I got
the
my
fuck
other two.
is
Oh, okay. All right, Bailey, hit us.
All right. So one of them is learn to do nothing. Like,
Oh, yeah. Just sweat it out.
there is just like there's two sides to that coin. Is one, a good anesthesiologist knows when and how to intervene. Like, we are interventionalists. Like, we love to intervene. We love to fluid bolus, atropine, start a pressor, add more drugs. But like, we love to do all that. But then we also know when to just sit back and watch and let something develop. And then like, don't like, so many people have this knee-jerk reaction to react and intervene, and sometimes just step back, reassess, reevaluate, like Beanie said, get your hands on that patient. And it's not like, no, like, be okay not always intervening. Like, I think that's sometimes I just sit there and I just quietly watch to see what's going to happen when people are like, what do we do? And I'm like, we're just going to sit here right now and we're
Yeah,
just
just
going to.
patience. Like my technicians told me last week when I was on clinics with them, they were like, they're like, Tasha, we know that you're more of a watch and see anesthesiologist. And I
Yeah.
was just like, Yes and no. It's just I have patience for letting
Yes.
things flush themselves out. Like
Yes.
if you bolus propofol really quickly and they go apneic, I'm not going to flip the ventilator on if you're
Yes.
saturating. I'm going to wait until the propofol redistributes and then I'm going to let you breathe on your own. And so they called me a wait and see anesthesiologist, which made me laugh. But I agree.
Yeah.
Like I have a little motto that I always tell when I'm training, which is anytime you intervene and you quote fix a problem, most of the time you also make another problem. Right. And then you spend the entire procedure chasing your own tail, no pun intended,
Yeah.
because you fixed a problem, made a problem, fixed a problem, made a problem, fixed a problem, made a problem, So, sometimes less is more. And so I think that
Totally.
tip is, God, we're agreeing a lot tonight, guys. Like,
Yeah.
No,
Oh,
I think that's a good point, but there are things where you do need to intervene, right? So
oh yeah.
if your blood
Yes.
pressure is shit, you can
Yes.
be waiting 20 minutes because you want to write it off.
I've taken lots of things off the table before with unreadable pressures that survive to discharge.
There you go. The only metric.
I don't do it on
Uh,
purpose, but it's just the way things go sometimes. But I'm going to intervene with one of my tips before we get to Bailey's third one, which is I find that, and this is almost a carry on from your comment, Bailey, about just leave things alone, and also a little bit Gianluca, like understand what's going on. But I'm a big believer in stop treating numbers on the screen, right? Like, so, like hands on the patient, waiting to do nothing. Like, I like to think about what's happening in the greater context of patient physiology, right?
mhm.
So, for example, you slam a whole bunch of, peripheral vasoconstrictors in there. Sure, you get a good number on the screen, but let's talk about what's happening to perfusion. Or, you want to ventilate a patient maybe who has been chronically alkalemic and you want to drive CO2 into a normal range, and then you completely like throw off their compensated blood pH, right? So you know taking that moment to not just, like you said, knee jerk, and taking that moment to put your hands on the patient, and it's not just about the numbers on the screen, it's how are those numbers being generated and what does it really mean in the face of what's happening in this patient in this moment.
That's my other one. Do not monitor the monitors because they will lie to you so many times. There's so many times I walk in and I look at the CO2 wave and it's just a little like this. And I'm
Can we
like,
talk about the problems you have with your CO2 at your hospital? Like, can
when
you
the
give us
patients
a
are
CO2
tachypnic or you're on a rapid respiratory rate and you don't get like that plateau phase, and it's like, well, CO2 is only 50. And then I'm like, yeah, crank up the vent. All of a sudden, CO2 is like 105. And I'm like, you need, like, we need to address the ventilation. This waveform doesn't give you any information. This waveform gives you garbage. And when you read garbage, you like do garbage.
It's very subversive attack on my CO2 comment from earlier and you trying to self-promote Dopplers, but mm, but
Yeah,
yeah,
the
no,
hospital would catch that for sure.
don't monitor the monitor, right? Don't react only to numbers. Like, what does the number tell you? And what in the face of what's happening with that particular patient? Like, is this patient bleeding? Is this patient
Yep.
profoundly hypothermic? Is this patient have good peripheral pulses? What color are its guts? Like, are you shunting in your lungs? Like,
Mhm.
it's that whole comprehensive way of pulling together and trying to think your way through it. And I
Yep.
feel like I know that comes with experience and more advanced training too, but like jumping down the throat of every number on the screen, I think is bad anesthesia.
The drive to make every individual number perfect,
But
you
with
know?
no context of what's really happening or what might be
Right.
appropriate. Like a
Yes.
CO2 of 35 might not be appropriate for that patient based
For
on
sure.
chronic pH or like acid base status or whatever's happening intracranially
Yep.
or what have you. So,
Mhm.
ooh,
So I have a
anyway,
question
and
for
my
you.
my other one is, by the way, is you have to understand the machine. You have to understand the damn machine, and I know it looks so intimidating. It used to freak me out too. Like understanding the machine, like the flow, what everything means, what it means when the various parts break, like what are your various safety mechanisms. But like I teach this real life machine talk, it takes me like an hour and a half and people will be like, That's more that I've ever heard about the machine in my life. And I'm like, but that's the fundamental thing. Like in theory, you should be able to build essentially a pneumatic machine from like parts in your
Yeah.
garage. Like, and if you can't understand flow and if you can't understand safety mechanisms and you don't understand the machine, then you really fundamentally don't understand a lot of the physics and the mechanics of ventilation. And also, things like inhalant uptake and all that kind of stuff. So, going through that machine is something I hammer at like once a month. I'm like, back to the flow meter, back to the vaporizer, like all that kind of stuff. Like, what are the safety mechanisms and what do they mean? And this alarm and that alarm. And, what happens if you knock the machine over, which, always happens with those stupid pull machines that are top heavy. And
That's what we have. I mean, the nice thing is they're so. I was thinking about your comment about understand the machine. The machine I have is so easy to understand. You can basically see all
yeah,
the parts of it.
you can
But
follow the flow of oxygen, right?
these really nice human machines, the anesthesia workstations, it's like,
You can't see anything.
which, there's pros and cons. Like that is
I
why
love
I
we
love them too. I think they are far
we have
superior to the like garbage machine I
so
have.
we have 8 Beta 5s from Mindray, and they're the most gorgeous, beautiful. Actually, no, we have 6, and we have 2 Wados, which are the
Yeah.
big brother thing.
Yep.
Mhm.
But they're amazing. Like
Yeah.
if you want the idiot-proof machine, that is it.
Well, that's the funny thing is those human machines are so much safer.
It is.
They're designed with safety in mind, whereas the veterinary does not have the same standards, obviously. And so the flush valve is seated in a certain.
Obviously,
Yeah.
obviously, we're shit.
I mean, we just don't have the same regulation because again, it's dogs and cats, right? And like horses and whatever. And like I've seen anesthesia machines where the flush goes right through the vaporizer.
Oh, that's exciting and
It's really
horrifying at
fun.
the same time.
I have seen people jerry rig a machine to have 2 vaporizers in series without an interlock.
Oh, that
Cool.
happens all the time.
Yeah, and it's incredibly dangerous.
It
Yeah,
is.
but if you understand the
It's
machine,
like
then
the
you recognize
fastest way to kill a patient.
yeah, oh, I don't agree it's the fastest way to kill a patient, but it's up there. But I think knowing that machine too, because if you understand, and this ties into my third one, which is it's know your basic principles, right? People get so tied up in like the fancy details of stuff. And it's like, do you understand oxyhemoglobin dissociation curve? Do you understand like the carbonic acid equation? Like it's really basic, fundamental understanding so that when things go potty, or like you said, you get that weird feeling, where you're just like, oh, something's going wrong. Like I can just tell that this is going to go south. But also too, like if you work in different clinics, like if you do a lot of locum work or you travel
Mhm.
or what have you, like half the time I rock up and I'm like, this is the first time I'm seeing this, right? Like there'll be some crazy like setup in like, a GP practice where I've gone in to teach. But if I can walk my way through like basic principles, like fundamental understanding of the machine, like I can follow the flow of the gas, then I don't have to have a panic about looking at something that I've never seen before because I'm totally like, how does this doodah work? Right. And I'll like, fiddle around with it. But basic principles, right? Like people they want anesthesia. I don't know. They want it to be like fancy or they want it to be, every case is so wildly different. And, we want to do all these crazy things and that's fine, but you can't fly until you know how to walk and then run. And if you don't have that strong grounding of the basic understandings of things like inhalant uptake, if what causes hypothermia, do you understand differentials for bradycardia? Please don't ask me to teach you an ultrasound guided block. It ain't going to happen. Right? Like if you can't give me 10 differentials for bradycardia, I'm not teaching you a femoral sciatic ultrasound guided block. Sorry.
The thing that blows my mind is how few people understand like the physics and uptake and like removal of inhalant anesthetics. Like how it's just like this grand mystery box of inhalant anesthesia, even though we do it literally every day.
Mhm.
Like it
I get
is
I get really like uppity, like my hackles go up when someone says like, "Oh, I really want to learn like ultrasound guided like psoas compartment or like erector spinae," and I'm just like, "Can you explain to me the mechanism of action of propofol?" And then you get like the blank stare. And I'm like, then no. Right. Like, I'm just like, sorry, like, you don't know how the drug that you use every day works. That is not safe. Go learn about that drug. Then we'll talk about like the bells and whistles.
Yeah.
Yeah. No, I mean, I think that sometimes people get wrapped up and they want to go straight to the fancy things when, actually a back to basic kind of approach is probably better, right? Like, but if you don't have the base, you can build a pyramid, right? Like, you need to have a
Yeah.
solid base. But some people don't care, and some people hate the pharmacology aspect of it, and like, but then again, if you don't know what the drugs do, what the hell, like, what are you doing? Is it trying to be a mechanic without knowing how the engine works? You know what I mean? Like, you can't really do that.
I like that little analogy. Yeah, that's exactly what it is.
Yeah. I mean, this is what I always tell, like, some of the practices we work with, right? Like, there is services out there that would sell you an anesthesia protocol, right?
Mm-hmm.
I can do that. Like, that's a PDF, probably pre-made. It's so easy, right? Like, but it's snake oil, right? Like, you can buy all the parts for to fix your car, but you know what you're doing, you're gonna fuck it up, right? Like, the what's important in anesthesia is the monitoring, right? The first question I always get asked is like, what's your protocol for this? What's your protocol for that? And my answer is, it doesn't fucking matter.
Yeah.
Like, in 99% of cases, you can anesthetize whatever with whatever drug, as long as you stay within the dose range. And it doesn't fucking matter. What matters is that you know A, how the drugs work, and B, what to do if shit happens. That's what you need to know.
But you
Like,
have to understand that they always want the perfect answer too. Have you noticed
Right.
that? Like, they'll give you a list of every drug that and all the problems, and you're like, every drug causes a problem. The
Oh
whole thing
yeah.
is are you anticipating it, and are you set up to support it? And
Right.
will you understand it when it happens? But yeah, I think
any
people
drugs, including fluids, you know,
get.
Yeah. I mean, that's like,
including
to the point about doing it the same every time. Like, we all essentially have, like, if you will, a plan A. Like, plan A is this, essentially. Like, we're going to use, like, this is my generic plan that I'm going to work off of to, like, run any case. And I know exactly how to time it. I know the way it looks. I know the drugs and, like, the
I call
dosing.
mine the Bartini.
Exactly. Like,
Right? Like,
everyone
I have a
has,
martini cocktail, and you
yeah,
could do 99.999% of every single case that comes in front of me with a
yes.
martini, and it
Yep.
will be fine.
Right.
And you just, when things go potty under GA, either because of what's happening procedurally or because the patient is, exceeded compensation, then that's really where the magic comes in. So
Right, exactly. And it's like, you can't, like, again, like that run, like, walk before you fly. Like, walking is figuring out your plan A, getting doses you're comfortable with, drugs you're comfortable with, like, reliability, and then starting to build in, change one thing at a time. Change, once you get comfortable with that, change another thing at a time.
like
With
that, yeah.
supervision, like, I'm not saying,
yeah.
like, just only do one case, like, one thing all the time, never change, like, that's the way to do it, but, like, at least until you're really super comfortable. And then when you're in a situation where you're not comfortable with the case or something, you at least have pharmacology and, like, a way the, drugs work to fall back on.
Yeah. I also find too, like, people when they talk to you about anesthesia and like writing the protocol, it is like such tunnel vision about the drugs and the doses. And to me, the protocol is everything from basically like patient admission, if not before.
Gosh.
Like, how is that patient prepped to come in? Is it stressed? Is it fractious? Like, was it fasted appropriately? All the way till survival to discharge, which they used to count at 2 weeks. Now we count at 4 weeks. So, it's everything about how you handle the patient, how you comfort the patient, how you nurse the patient. Like, the protocol is not just methadone, dexmed, propofol, ketamine, right? The protocol is the entire management of the patient to mitigate stress, to mitigate pain, and to optimize outcomes, right? Anesthesia doesn't end when you just pull the tube. It's not salt burn, right? Like it's,
Although that tube is definitely a veterinary tube, for the record, 100%. That's like a 51 French or something like
out of
that. It's
all the horror
so
movies I've ever
long.
watched, and I don't like horror movies, when he extubated her in Saltburn, I almost vomited. Like I was just
That
like,
was
oh,
insane.
that scene is so disgusting to me. I
That
hate it.
tube is so long.
Gross. But yeah, no, the protocol is not just drug selection. The protocol is patient management and increasing survivability or ensuring survivability. So, like I said, it's like, where are you going to put your catheter? Like, what if it's a bulldog and it has skin disease and like it's wrinkly and it's obese and it can't breathe? And when you sedate it, it turns blue. Like, all of that is the
And we're
protocol.
doing a four-limb mass removal and like
Yeah, like the cow has a fractured tibia and they brought it in here and my induction stall is half a kilometer away.
right.
Like that is the anesthetic protocol. So I think that there's such tunnel vision about like the drugs and like what to pick and how to pick and not nearly enough focus on everything else that has actually a much bigger impact. So yeah.
Just like the Jaha anesthesia guidelines from like, I don't know, 2020, 2022, are like anesthesia starts at home. Which it does. Like, especially with the
It
advent of
does.
oral anxiolytics
Right?
and sedatives and
Yeah.
stuff, like
Like, are
anesthesia
you going to
starts.
sedate it? Is it going to vomit in the car? Is it painful? Is it decompensating? Do you need
And
to
are
have
we gonna start
oxygen ready?
starving it? Everyone can't wait to starve it. Let's starve it. We're so
Yeah.
fixated on starving these goddamn animals.
Well, yeah.
Um, yeah,
I
no,
mean,
I agree. It's crazy, right? Like people don't have this. Yeah, they're so focused, right? They're so focused on this,
And
the
they're so
fucking
worried that
drugs.
like they're like, "Well, would you give 2 of Dexmed or would you give 3?" And real
It
honest to
doesn't
God,
fucking matter.
yeah.
It
no one
doesn't
cares.
fucking
I'm gonna
matter.
round it up to the next whole integer.
I do laugh though when people do things like, "Well, I gave 2.5 micrograms per kilogram of dexmedetomidine." And I'm like, "Oh, did you?"
Wonderful. Good for you.
Or when they turn the isoflavone vaporizer, I turn it from 1 to 1.1 and I'm like, "Oh, did you?"
This 4.5 kilogram cat, I gave it exactly 1 microgram per kilo of dexmedetomidine. No, you didn't. You gave it 5 micrograms and you moved on with your life because you have better things to do, or at least I fucking hope so.
Yeah.
It's
Anyway,
crazy.
those are my random stuck on anesthesia only island questions. And I do want to shout out to our number one fan, Leslie B, who gave me the idea for tips and tricks too.
Mm.
There's a vet tech out there who absolutely loves our podcast and like shares it every week and like
Oh
is so enthusiastic. And I told her I'd do our shout out to her in this podcast. So Leslie,
yeah. Oh,
we appreciate you. We love you. And thank you for sharing our little sessions here on veterinary anesthesia and all the wonders of the culinary world.
yeah. Thank you.
Thank
Wow,
you.
we have a fan. It feels very exciting.
Yeah.
Yeah,
Like
I
that
think
one guy has
some.
no taste in food.
I mean, I have a couple of friends who listen to it and they're neither vets nor anesthetists and they really enjoy it. And they're like, wow, I really learn a lot about things I don't understand at all. And I'm like,
I mean,
great.
I've got a friend who is a professor in like engineering or some very like he does laser and quantum computing, and he's like super super smart. And he listens to this podcast. He's like, I understand none of it, but I love it. He also loves wine, so I'm sure I'll be interested to hear his feedback on our desert island wine discussion.
Honestly,
Do
I could
we
have a
have
whole podcast I could do a wine podcast separately. Like,
Sure.
I love talking
100%?
about viniculture, but yeah.
I actually brought our podcast up today because we were anesthetizing a patient, and the technician had chosen lidocaine as part of her plan. Lidocaine CRI, of course. And I was like, yeah, it's fine. And then the patient's a little hypotensive under anesthesia, whatever, no big deal. She's like, well, should I turn the lidocaine up to further reduce the inhalant? I was like, well, you could, but my colleague thinks it's a fucking waste of a pump, so I wouldn't worry about it. And I was like, plus the reduced cardiac output and like the MAC reduction you get tends not to outweigh the reduced cardiac output. So I would just move on to pressors at this point. I mean, in humans, it's crazy. Like because I know what happened to Brosnan when he reported a story at Davis, I think, when he was getting like a toenail removed or something. And he said he started to feel woozy. And then the next thing he knows, he woke up because like we were in a lecture for human anesthesia residents, and they were discussing local anesthetic toxicity. And they said, if the patient reports ringing in their ears, the next step is induced anesthesia.
Oh, interesting. I mean, there's a
Because,
huge amount of local anesthetic allergy too, not just toxicity, but like I think
yeah, that's
37% of women who receive epidurals for birth have an allergic reaction. Like that's
wow.
a monster number of
Yeah,
people.
that's
And like they
crazy.
often report like they'll get tingling in one limb and not another,
Oh,
or like they're only hemiplegic type thing, but it's very, very common. Like people do not do well with locals. We
yep.
have a lot more forgiveness, for example, in like dogs. And I mean, how much lidocaine do you give a cow for a standing cesarean, right? Like a bottle.
Well, like
So,
in humans, I guess they do because they need to secure your airway. Because
mhm,
if you get local anesthetic toxicity, the first step is secure the airway, and that's why they induce anesthesia, just so they can have your airway in case you have like respiratory arrest. They can
yeah.
like be ready to intervene at the jump. So I was like, whoa, that is like
Yeah.
crazy. They also report like, surgeons essentially just like injecting local anesthetic without abandon,
I had
for
that happen once in a dental case where basically it was just mepivacaine in a cat and it was just like hosing it down, like, because it was full mouth extractions and the cat actually fibrillated from a local anesthetic shock. It started getting like, weird twitching under anesthesia. And I was like, that's not the alfaxalone. And then it went into fibrillation.
Yeah.
So I gave that cat intralipid. That's how I treated
nice.
that cat. And that one did live, but it was a mepivacaine arrest from you know, just the volume and like the rapid uptake from a highly vascular area.
I saw on another note, I saw something I have only theorized should occur in cases, and I was like, dang, that's cool.
Only one?
It's less
We
cool
had
when
a
you say
patient
dang.
We had a patient for a hemilaminectomy, and it was on fentanyl, as they are. And we gave atropine to try and increase heart rate slightly, but the low dose, and we slowed his heart rate down enough that he went into escape. I
Oh.
was like,
What dose did you give?
just like the usual, like I usually do the 0.01 mg per kg of atropine per dose. I know, more like I know the presynaptic effect. I know, but like generally it works well. I've done it forever. I've
And
been, and I was like, I walked in like the ECG is doing something weird. I walked in, I was like,
Mhm. No shit.
oh, cool. We're in like third degree with escape.
Time
I
to
was
get
like,
more.
So wait, what was your next step?
well, I walked in the room and I initially noted the P waves. And I was like, all right, we got hella P waves. We'll be fine. And then I was like, oh, dang, that's an escape rhythm on top of what probably is an atrial rate of 120. So yeah, I was like, what do I do? Am I patient enough to like watch a patient in third degree AV block without creating a hullabaloo in the OR? Or do I give more atropine, push the atrial rate higher? So he gave more atropine, which then invariably fixed the heart rate issue, but then pushed the blood pressure sky high, which, what are you going to do? I mean, it's always a great question. It's like a Frenchie, so like how accurate is the blood pressure in the first place?
Maybe you should put
Like,
the Doppler on.
I mean, I was like, maybe we should put the Doppler on the patients just to check these. Yeah, it's never made sense to me how you can slow the heart rate down to 30 to 40 in a dog and not go into an escape. And like finally it did. And I was like, dang, everyone's
Sure
like
does.
PVCs. And I was like, they're not premature though. There's nothing else going on. It's all ventricular rhythm. This is an escape.
Jesus.
Exciting.
That was cool. That was
Awesome.
cool. If the dog hadn't been an escape, I probably would have let it. I probably been like, just wait. Those atrial beats will kick.
Yeah.
That atrial rate will start going through
So
the
why the
nose.
0.01?
It
What's your
works.
thought process?
That's not. It's such a bunch of crap, especially in a state of low cardiac output. It for sure does what you
It
just said.
works. It works.
Does not.
It does. And then I don't have their heart rate skyrocket to 200. I'm less likely to get
It
their
must
heart
be
rate.
fancy Chicago atropine because
I mean, it's
So
also
like
the fancy California atropine.
is it like tavern style hydropine?
Yeah, exactly.
bring back Marv.
He's hanging out in his box. He was here. He was scratching me on the back of the neck because he wanted to get on the podcast.
Well, Marv is our special guest tonight, everybody. And Marv
Oh,
Special
also
yeah.
guest.
hates the
Well,
Doppler.
Sold cat.
Oh, Jesus, guys.
Yeah.
Unbelievable.
Yeah.
So here's my last question, and then I think we reached the hour, so we probably should let the listeners go. So, you were talking before, Ryan, about how,
Oh gosh.
sometimes they may not give you the right.
Ooh. Don't get
Um,
me started on the monitor real quick, because I got a lot of feelings about monitoring equipment if you want to.
well, I mean, here's the deal. So, first off, I'm not, the moment you said that your favorite piece of equipment is the Doppler, you lost all credibility. So, I'm not going to listen to your BS. But the question is,
Christine will support me.
Who will?
Christine,
Oh,
my
Christine.
resident.
Yeah, I know who Christine. Yeah, she probably will because she also, went to the same school. But
but so if you see, let's say, you see a blood pressure and you're like, it may not be real,
Yep.
you believe it or may not believe it, right? Like, do you still record it?
So that's a great question, and I wrestle with that all the time. Like the
I
Frenchie.
only record values that make me look like a great anesthesiologist. As a quick,
Oh yeah, opportunistically, we only have to record every 5 minutes, guys. So like,
I
yeah,
only write down the good numbers.
yeah. If like blood pressure's hanging out in 40, 40 map for like four 4 minutes and 59 seconds, but one reading came in under the wire at a map of like 70. It's like, dang, look at the normotension. Just kidding.
Okay, okay. Um,
No, uh,
whoever's
that's it.
listening, I believe it. That's a joke.
Yeah. No, but like what it happens all the time, right? Like
Yeah,
chondrodystrophic dog, cat who's shocky. Your volume says you're doing things under anesthesia to support this patient, but like you're not getting a reading, and you're trying to balance like, gosh, we went from prep to the OR, two different monitors. Now we've got different readings that are super discordant. How do we treat this patient without intervening? So in like, I think that's a really good question I wrestle with all the time is the honest answer. But usually in that situation, if I have blood pressures, because you can on the modern equipment, you can watch the little bar. Like some of ours, you get a little bar, and you see the bar go up, and then it goes down, and then it goes up again. And you're like, all right, well, now we have some trouble. I usually note in the record like uh, non-invasive blood pressure, not reading or giving artifact, suspect, da da da.
gotcha. So you make a
Uh,
note of it for liability purposes.
Yeah, that's what I do. I mean, I write the numbers down if there are numbers given to me. I will say some of our equipment will just like, I don't know, like just not read. And I find it again, it's always
It sounds to
it's
me that you need new monitors.
well, it's the same culprits though. It's the dachshund with the leg that's like, you know, a hook, and like the Frenchie who's, the right above the paw is this wide, but right at the elbow it's this wide, and you're like, which cuff size do I select? The
It sounds
5?
like you need either buy new monitors or place more art lines.
Yeah, but like, are you really placing an art line for like a straightforward like Frenchy hemilaminectomy? Like, come on,
Yeah,
come on.
yeah.
Yeah, it's not a benign procedure. There are
Again,
complications, and
not knowing what the fact the blood pressure is doing, it's also non-benign.
but blood pressure, like invasive blood pressure, is always the most accurate. Like there are tons of times where the blood pressure readings are inaccurate on the invasive. I mean, not as often, but like that
But
monitor is also
map
prone to
is
errors.
accurate, which is the
Do you
only value
do you
you care.
re-sterilize your equipment though? Your blood pressure equipment?
You do what?
Do you re-sterilize your invasive blood pressure equipment?
No, trash
Mm,
it.
I mean, that's nice. That's nice. Must be nice. Like when you have aberrant blood pressure readings, or your like blood pressure equipment is cycling, and you're in the you're committed to the case at this point.
I mean, I'm always committed to the case.
No, but like you're in the OR, you're not still in prep, getting
Oh, I
ready.
see.
Like you're like in a
Well,
point where like placing an art line will be a technical challenge.
So yeah, usually, our brand new monitors, they work really, really well.
The one we have trouble with the most is the MRI, but it
Yeah,
generally reads really well. It's just, I mean, MRI is obviously prone to a lot of technical challenges in and of itself.
it's unfortunately those are pieces of shit. Right?
Yeah,
Those monitors are
yeah,
Agreed.
yeah.
they're
I
straight
mean, it's
pieces.
hard. Like, it's got to be all fancy and like super long lines, which just then creates like all this. Like, you're talking about,
I mean,
the blood
oscillometric.
pressure.
Once you have, intrinsically, if you make the tubing longer, you're gonna have way bigger variability, right? Like your deviation is gonna be huge,
Yeah,
just because the oscillations of pressure that they're looking at, they're so tiny that intrinsically they're gonna be shit. So those are the ones where you know it's yeah, I always struggle with those. No. But anyway, well, thank you everybody for listening. Next time is going to be probably my turn for the next topic. We may have a special episode in between, so we'll keep you posted on that on our Facebook, Instagram, and all that. Thank everybody for listening.
Thanks,
See you
guys.
thank you.